Welcome to this IAC Educational Fund virtual meeting. Thank you all for joining this meeting. My name is Dr. Patience Mawunganidze. It is session 4 of a workshop that has been going on. And the last mile, the longest mile, realizing the promise of an AIDS-free world, Southern African Regional Workshop. Thank you all for making time to participate in this session 4. I would like to let you know about the aims of and the focus of this workshop that we have had from 25 to 26 March. And we've been discussing topics, and 4 main topics. And the first one was on pre-exposure prophylaxis, taking the anxiety out of sex. And the second one was talking about responsive clinical care to improve developmental outcomes of infants and children affected by HIV. And the third one was Children Lives Matter. When did we stop caring? And the fourth topic that we are going to be zeroing in on today is there any health without mental health? We also have a group work that is planned this afternoon, where we are going to build consensus on 3 main domains or actionable items, that is on stigma, discrimination, and mental health in Southern African region. I would like to thank those who came up with this topic. Is there any health with mental health? I'm a psychiatrist. I'm the Deputy Director Mental Health in the Ministry of Health in Zimbabwe. And I face this problem every other time, where we have people who are in government or in clinical work stigmatizing our patients, stigmatizing us as their colleagues. And it's only now, like in the past, like last year and now with the COVID-19 pandemic, that people have started to realize the importance of dealing with mental illness or people with mental disorders. People have now realized that anyone can suffer from anxiety, depression, and other conditions. And I am glad that this workshop is also focusing on these issues that we were also has been affecting us as a nation. I would like to hand over to Lauren, who is going to give us housekeeping issues. Over to you, Lauren.
Yes, thank you very much, Dr. Mawunganidze, for those opening remarks. So hello, if you've participated in our previous sessions, you by now know me quite well. So I'm just reintroducing myself to those of you who are joining us just for this session. My name is Laurent Botti. I am the Associate Project Manager of the IAS Educational Fund. I am also here connected with my dear colleagues, Laure Felix Bauer and Camilla Fontura, who are here behind the scenes and making sure that this session is running. So I just wanted to say thank you all for joining us for this last session. We're really excited to have you here. And thank you to all of you who have participated right through to the end. For the moment, you're all muted, but we will be able to unmute ourselves when we go into the group discussions later on for the second part of this session. For the first part, we will be looking at a presentation, and then we'll move on with the great breakout groups into a different link. For the moment, if you could please just introduce yourselves, if you're connected, just on the chat below, if you could please share your first name, last name, the organization you work with, and the country you're from. This helps us have an overview also to see how many people are connected in this virtual world from around the globe, specifically Southern Africa region countries. So if you could please do that now, also for us to see who was able to connect, that would be great. Thank you very much. You are also able, outside of session hours and also during session hours, to chat with anyone you'd like. Further down below your screen, there's a chat option. You can also invite people for video meetings. So please use that as much as you can, or we're really trying to encourage you to network with those means. I'm also happy to say that this workshop is CME accredited. Sorry for those of you who have heard this already 3 times over. But if you have been able to participate in all 3 sessions, that means that you'll have been able to have various credits for this workshop. If you are interested in getting these credits, please contact the IS Educational Fund team at isedu@issociety.org, and we'll be able to give you more information on what we need from you in order to be able to provide those credits to you. Then the last thing I wanted to say is we also have some pre-reading material available on the platform. So other material will also be available in the similar area. So if you actually click on resources, it's a tab that's at the top of the platform. You'll be able to find the recordings of the session there, the presentations of the sessions that have passed before this one as well. Eventually, we'll be able to put all that information up for you, but that's exactly where you'll be able to access that. As soon as this meeting is done, around sometime soon, we'll also be sharing a report of the meeting with key recommendations based on the actionable items that we've been able to put together up until today. So that will be something that I highly encourage you all to also regularly check and see if it's there, in case that's something that would interest you to access later on. And now I am just to make this more active, let's launch our polls, please. So we have a poll that's just to see how you're feeling this afternoon. So we had one earlier this morning. So if you had to participate in the poll this morning, let's see if you're still feeling great, because the majority of you were feeling great. And otherwise, please just share how you actually feel in the chat. That's also super welcome. Let's see what the results are. Okay, so I see that most of you are still doing great. A lot of you are excited as well and curious. So I'm happy to see the more positive results coming out from this poll. So now we're going to ask you also, what are your expectations for this session? And this is the second poll. We're just waiting. There you go. You should be able to see that poll on your screen now. So what are your expectations for today's session, this afternoon session? Gaining a better understanding of HIV science and new developments, getting ideas and finding solutions for challenges that you might face at work, getting any new ideas on how the latest findings in HIV can be applied to local issues. Let's have a look. Okay, so 50% finding new strategies on how to improve HIV policy and programs regarding implementation science. So this is great for the group discussions, finding new strategies. We'll try to engage, and please, those of you who have selected this, please suggest any ideas you may have for our discussion later on today. So thank you very much. And with that, I'd like to pass back to Patience to please introduce our keynote speaker. Thank you very much.
Thank you so much. I would like to introduce Jacqueline Hall, who will be presenting on a systemic approach to mental health and HIV. Jacqueline is professor from the Department of Mental Health at the University of Cape Town in South Africa. And I would like to hand over to you, Jacqueline. Over to you, Jackie.
Hi, can everyone hear me?
Yes, we can hear you.
Right, and my slides good? Okay, I'm going to be presenting a literature review of common mental health disorders in adults living with HIV. And this review summarizes the most recent literature, as we only include publications from the last 2 years, 2018 to 2020. Right, so people living with HIV are at risk of common mental health disorders, including a higher suicide burden. Poor mental health has been associated with HIV disease progression and poor adherence to treatment, making the treatment of mental illness alongside HIV key to strengthening HIV care and outcomes. Common mental health disorders may exacerbate many of the social and economic barriers to accessing adequate and sustained health care, and are among the most challenging barriers to achieving sustained viral suppression. In fact, the burden of common mental health disorders is likely to have been underestimated due to the lack of appreciation of the connectedness between mental health and HIV. Mental health can affect progress towards the achievement of many sustainable developmental goals, such as gender equality and empowerment of women, improvement of maternal health, and of course, ending the AIDS epidemic. Women living with HIV have a higher burden of common mental health disorders compared to women without HIV and men living with HIV. Mental health issues in women living with HIV, such as depression, post-traumatic stress disorder, and anxiety, are associated with poor quality of life and worse HIV outcomes. Mental health symptoms, particularly depression, are also widespread amongst pregnant women living with HIV and have the potential to affect quality of life and clinical obstetric outcomes. Intimate partner violence is a global health epidemic, is a global health problem of epidemic proportions, with strong evidence that the risk of intimate partner violence is heightened in women living with HIV, and emerging evidence linking experiencing intimate partner violence and HIV to an increased risk of mental health problems. This triple burden makes women in Africa living in the epicenter of HIV all the more vulnerable. Mental health problems in people living with HIV has been quantitatively associated with many other vulnerable groups, such as conflict-affected populations, transgender and gender non-conforming people, sex workers, incarcerated people, and men who have sex with men. By reviewing the most recent common mental health disorder studies in people living with HIV, we discuss the prevalence of common mental health disorders, factors associated with or drivers of mental health disorders in people living with HIV, mental health in people living with HIV from vulnerable groups, the impact of common mental health disorders on HIV disease progression, the impact of common mental health disorders on adherence to antiretrovirals and treatment outcomes, and the efficacy of different treatment approaches, including psychosocial interventions and psychopharmacology. After screening for eligibility, 142 studies were included in the final review. However, only 27% were studies conducted in sub-Saharan Africa, which carries the highest burden of HIV disease globally, with the remainder of studies being conducted in the USA, Europe, and Asia. All studies included people living with HIV of 18 years and older, and the age range was 18 to 54 years. Despite the well-established increased risk of common mental health disorders in people living with HIV, the current prevalence remains high, with studies reporting 28 to 62% of people living with HIV having mental health symptoms. Depression remains the most common mental health disorder, with reported prevalences ranging from 14 up to 78%. Severe depression prevalence ranges from 18 to 22%, and lifetime suicidal ideation was identified in 23 to 38% of people living with HIV, with 21% reporting suicidal ideation in the past week and 28% reporting in the past 2 weeks. High perceived stigma was associated with increased suicidal ideation. Anxiety disorders, particularly generalized anxiety disorder or GAD, are also commonly comorbid conditions in people living with HIV, with 25 to 33% experiencing clinically significant anxiety. Internalized stigma has a significant indirect effect on anxiety through self-blame. Generalized anxiety disorder is associated with condomless sex, HIV stigma, poor adherence, and reduced sustained viral suppression. People living with HIV from vulnerable groups, such as perinatal women living with HIV, low-income women living with HIV, survivors of sexual assault, transgender and gender non-conforming people, gay and bisexual men, MSM, prisoners, and migrants are particularly at risk of common mental health disorders. In perinatal women living with HIV, experiencing internalized stigma significantly increase the odds of reporting depressive symptoms. Suicidal ideation is most likely to present and be sustained in women living with HIV experiencing intimate partner violence. Gay men living with HIV are reported to have poor recovery from depressive and anxiety symptoms 1 year after diagnosis. Suicidality remains common in MSM, who have significant associations between lower general self-efficacy and depression or anxiety. Within this population, major depression and internalized stigma are highly correlated. Transgender women have twice the odds of significant depression compared to MSM. Prisoners with perceived stigma due to HIV status are more likely to be depressed. 1/3 of migrants living with HIV report experiencing psychological distress. Therefore, the screening and treatment of common mental health disorders should be essential in improving HIV care in vulnerable populations. People living with HIV who are vulnerable to common mental health disorders frequently face significant individual, structural, social, and biological challenges to accessing and adhering to ART. These factors may be socio-demographic, local environmental factors, social structures, individual factors, and HIV stigma. Depression in people living with HIV is significantly associated with lower social capital, unemployment, and low food security. In addition, greater functional limitations, poor self-coping strategies, low community support, internalized HIV stigma, and poor self-esteem, poor resilience, and substance use are factors associated with common mental health disorders in people living with HIV. Those who report negative life events that include financial problems, discrimination, conflict, and problems with childcare were at a higher risk of depression. And so are individuals with chronic stress who have a higher risk of mental health problems than those experiencing acute stress. Depressive symptoms are associated with subsequent viral non-suppression through its association with self-efficacy and ART adherence. Sustained viral suppression is more likely among people living with HIV with no depression and good self-efficacy. There's also an association with higher stigma, increased levels of anxiety, sexual assault, recreational drug use, and depression with subsequent poor adherence. People living with HIV with depression and without disclosure of their status to others are also more susceptible to poor adherence. In addition, adherence to ART, symptoms of poor physical health, and depression are strongly associated with functional limitations and disability in people living with HIV. There is evidence that common mental health disorders and stressful life events can negatively impact, without adherence accounting for this, can negatively impact HIV disease progression, including decreases in CD4 cell counts, increases in viral load, and an increased risk for clinical decline and mortality. Findings also suggest that immune activation might be involved in depression risk in people living with HIV. Cortisol concentrations and inflammatory cytokines are higher in depressed people living with HIV and are related to poor learning and memory. There is now reliable evidence that depression is associated with neurocognitive impairment and neurocognitive decline amongst people living with HIV. So more research is warranted to investigate the biological and behavioral mediators of these psychoimmune relationships and the types of interventions that might mitigate the negative health impact of depression in people living with HIV. All treatment or intervention studies for common mental health disorders in people living with HIV investigated behavioral and psychosocial interventions, with the majority of studies reporting improvement in mental health symptoms. The interventions ranged from cognitive behavioral therapy, group support, interpersonal psychotherapy, problem-solving therapy, mindfulness-based stress reduction, to behavioral activations such as fitness, lifestyle education, and anxiety management. Studies also included online interventions, including guided online self-help for depression and a WeChat-based intervention for suicide ideation, as well as telephonic administered therapies. So it seems, given the wide range of successful treatments, that the common thread to these interventions is providing people living with HIV with much needed support, social connections, and positive therapeutic relationships. Interventions delivered by lay health workers, community home-based carers, and nurses were only investigated in 3 studies, which is concerning, given the limited number of psychiatrists, psychologists, and other mental health professionals working in low middle income countries where HIV is endemic, such as sub-Saharan Africa. Several systematic reviews have supported the use of task shifting for mental health focused on specific populations, such as people living with HIV. In addition, few studies investigated the integration of mental health services with HIV treatment services. Mental and physical health are interconnected, and early detection can lead to improved treatment outcomes and increase cost effectiveness for healthcare systems. While the evidence base for mental health treatment or interventions among people living with HIV is encouraging, the majority of research on mental health treatment or interventions has been conducted in high-income countries rather than low-middle-income countries, which really is a profound mismatch for the global burden of HIV. In conclusion, despite the significant challenges that common mental health disorders present to successful HIV treatment There are many mental health treatments and interventions which can improve outcomes in people living with HIV, and many opportunities to task shift as well as to integrate mental health care with HIV care. The evidence presented here of online and telephonic interventions which are effective are worth exploring due to COVID-19. However, many of the most at-risk populations in low middle income countries are also the most likely to have difficulties accessing the internet and adequate cell phone reception. I'd just like to thank my amazing team, Sarah, Bulalwa, and Nicole. It really is quite a mammoth task during a systematic review, including almost 150 studies. Thanks, everybody.
Well, thank you so much, Jacqueline. This was a really, I would say, encouraging presentation to hear of this increased evidence base in terms of prevalence. At least this is helping us to understand the prevalence and the need for interventions, and also that there's increasing evidence around the sorts of interventions that are effective. But as you say, it's alarming to hear that there's such a gap in terms of this region of the world and where these interventions are greatly needed. So thank you so much for that. I'm Nicola Willis. I'm from Africaid and Jandiri program here in Zimbabwe. And I have the pleasure of facilitating the questions and answers in response to Professor Hoare's presentation. So I'm looking in the chat box, and as far as I'm aware, can't see any questions so far, which I always take to mean that was all brilliantly explained, very clear, and we've been left with nothing further to ask. But I'm going to kick off with one question, Jackie, if that's all right. A lot of what I work in the field of adolescent HIV, and a lot of what you just presented mirrors what we're seeing in adolescents as well. But one thing that struck me in particular was around the prevalence data and these very broad percentages in terms of prevalence. And I wondered if you could shed some light to that. Was this because of, different, what were the trends there? Was it to do with different regions, different populations, etc.? Does that make sense?
Thanks for that question. So yes, I think you've partly answered that question. One of the issues is, this was a global review. And I suppose access to healthcare globally is incredibly variable. So part of the issue here is that the studies included in the review were conducted across the globe, with the higher prevalence rates reported in countries with poorer access to mental health care. The other issue, though, is that the screening tools for measuring depression were incredibly variable. In actual fact, 14 different screening tools were used. So I think this is probably something that's worthwhile also in terms of future research directions, is to try and kind of standardize the mental health screening tools that we are using so that we are able to compare. In actual fact, one of the studies included 3 different depression screening scales. I think the one was the PHQ-9 and the other was the CESD. I can't remember what the third one was, but within each individual, within each, in using each of those 3 different tools, the prevalence rates were completely different. In actual fact, that was the study that reported the highest prevalence was a study which used the PHQ-9, and that was where the 78% came from. But within that same study, studying the same individuals, I think there was a 60% and like a 58%.
Thank you, Jackie. That's really helpful. Any other? I'm just looking on the chat. I'm technically challenged, but I'm doing my best to juggle between these screens. Any other? Okay, so we have one question here. Mental health is often not prioritized for HIV funding. How can we change this? There's a question, Jackie.
I I actually think that there is a shift. I think that there have been many difficult, traumatic, and horrific things that COVID has presented us with. But what COVID has done is it has highlighted the importance of mental health care. And I do believe that both the NIH and Wellcome are really interested in mental health work and mental health studies. So I hear you, but I do believe that there is a shift. I mean, mental health is just far more prevalent. Even, I mean, you can turn on the television and mental health is being discussed on CNN, on BBC, you know, the same thing on social media. Probably the only positive thing I can think about COVID-19 is that it has kind of normalized the discussion that talking about mental health is okay, and that needing mental health help is because of the pandemic, not because there's something wrong with me. So that has allowed for more people to talk about and access mental health care. So I think we need to ride that wave. That's probably the wrong word to use in the COVID pandemic, though. But yeah, well, it's shifting.
I hear you, Jackie, and I often think of the fourth 95 in the HIV care cascade that's really been quite silent, apart from, you know, certain people, you know, trying to push that and advocate for the fourth 95, and that there does seem to be a shift. I think this, certainly over this last year, of people recognizing the significance of that. So hopefully within the HIV world, we can keep advocating using the sorts of data that you've been sharing and really advocate for this combined approach and leveraging off the HIV funding to get attention for mental health, but with this combined approach. So thank you so much. Lorraine, I'm over to you. I see we're up on time, is that right? Okay, so Professor Hall, thank you very, very much for your time and for sharing this fascinating presentation. Over to you, Lorraine, I think.
Hi, yes. So we're just going to have a 5-minute break now, but at the same time, we'd ask you to please click on the link that's provided on your screen, and this will be the shift that we'll take to get to the group discussion. So please make sure you click on the link, and we'll be able to welcome you in this other Zoom window, and that's to make sure that everyone can participate in the group discussions and can unmute themselves. So please make sure you do that, and while you're there, you can also take a break because I know it's quite a long session, so you can use this opportunity to go get a drink, go take 5 minutes, and we'll see you for the group discussions. Thank you so much.